welcome everyone. For those of you who don't know me, I'm Anna Richmond. I'm one of the Obs and Gynae trainees at UHL. We decided that this week we'd do a bit of a joint teaching session between obstetrics and ITU to speak about the intensive care management of the pregnant patient. And we've got I don't recognise everyone's name, so we should have trainees from Obs and Gynae and ITU, but then also we've invited some of the ITU nurses and midwives from UHL, and then there's a number of consultants across both specialities have also been invited to attend. So I hope that you will find it very interesting. A bit of housekeeping, because there's going to be potentially more people on the chat than normal. Just be a bit mindful that your microphone's on mute. If you have any questions, put them in the chat and we'll try to have time to come to them at the end. And Dr. Whitman will put a slide for feedback, because there's different links for feedback. So just be mindful that you complete the correct one at the end to get your certificate. So, Dr. Whitman.
So for those of you who don't know me, I'm normally one of the intensivists at the Royal and do anaesthetics as well. So yeah, I sort out teaching from our side rather than from the obstetric side. So welcome to come into all of our joint teaching. And Dr. Smith should be there and is going to talk to us all. He's one of the intensivists at the Royal as well, and is our obstetric liaison critical care person.
Okay, so we're going to talk about maternal critical care. My name's Martin Smith, and I'm one of the consultants at Leicester Royal Intensive Care. And one of my interests, or one of the things I'd like to develop a proper interest in, is kind of intensive care of the maternity patient. So that's why I'm giving this talk. Right, so just as a brief introduction slide, if the slides aren't changing and things, please just tell me. So we're going to talk about why is it important, why we're here having this conversation. We're going to talk a little bit about levels of care and kind of how they're defined. We're going to talk about who needs to come to the intensive care. There's a few challenges specifically for pregnant women for us on intensive care. Of course, we can't avoid talking about COVID, because we just have to talk about COVID all the time, don't we? And then hopefully just a little bit about kind of the future. Okay, so why are we here talking about all this stuff? Well, so for the intensive care trainees, some of you may not be aware of something called the Embrace report. So every time there's a maternal death, they kind of collect information about it and try and work out what's happened, and they publish a report every few years. And in the most recent Embrace report, there were 191 women died from direct and indirect causes, which is about an 8.8% per 100,000 maternities, which is not an insignificant number of people. Just a brief definition of what that means. So a direct death is somebody who's died of something specifically related to their pregnancy, so something like massive hemorrhage or preeclampsia. And an indirect death is something where somebody has possibly a pre-existing disease, or they developed another problem during their pregnancy, and that's what they've died of, but it's not directly their pregnancy that's killed them. So what did people die of? Well, the majority of people died of, the majority of women died of pre-existing cardiac and neurological problems, so indirect deaths. But of the direct deaths, thrombosis and thromboembolism was still the leading cause, followed by hemorrhage and sepsis. And then, as you can see, there's a few other things as we go down. And what the Embrace report does is it compares the kind of rates of what's happened to people with each individual report. And what it says this time is that the maternal death rate from major hemorrhage is about the same. It's about 0.64 per 100,000. There's a small decrease in people committing suicide, but we're not going to talk about that. Thrombosis and thromboembolism, as we said, remains the leading cause of death. Maybe slightly better, but you can't really say that there's any change. And possibly slightly worrying is that sepsis deaths have continued to rise. And one comment they do make on this most recent report is that if you think somebody is unwell and they might have COVID, also remember that they could have sepsis and need treating appropriately. Why is it important that we get together as a kind of multidisciplinary group and talk about these things? Well, across the country over the last few years, there's been a lot of what I'm just going to call maternity scandals. There've been a lot of problems in maternity units. including quite local to us in Nottingham. And the overriding theme from these reports is that there is kind of problems in the culture of the units. So failure to recognise problems and act appropriately, poor communication, a failure to learn from mistakes. And as a result of these things, mothers and babies have died. Okay. So interestingly, for a talk on intensive care and maternity, my opening statement will be that most women do not need to come to intensive care. And I would argue that intensive care is not the right place to look after most either pregnant or recently pregnant women. So we can talk a little bit about models of care in a minute, but why do people need some kind of enhanced care above and beyond what is normal? So this is a slide I've stolen from a talk at the Intensive Care Society meeting. This is data based on coming out of Yorkshire and Humber, I think, about why people needed enhanced maternal critical care of some kind. And the first circle on the left, first graph on the left, shows that the vast majority of people who need some kind of enhanced care need it in or around when the baby's being delivered. So kind of immediately intrapartum or immediately postpartum. There are a few, there are some that come in before that, but the vast majority are related to actually coming in to have the baby. And then the modes of delivery, again, the majority of people who needed some kind of enhanced care have had emergency cesarean sections, but then, there's a reasonable number of people from kind of every other form of delivery. Why do women require enhanced care? And I don't think there's any surprises in this from anything that we kind of see on a day-to-day basis. The vast majority of people who need some kind of enhanced care have had a postpartum hemorrhage. There's also people who have hypertensive disorders and sepsis, make up about 15% each. COVID's crept in there on this data for about 5%. And then, of course, a small number of all the other contributing factors. Now, most of these people don't come to intensive care. So we probably see in Leicester Royal, excluding the last kind of run of kind of COVID admissions, we probably see about one obstetric patient a month on average-ish. Maybe that's slightly more than we see, but something in that region. So what kind of levels of care are there? And these are things that are defined by the Intensive Care Society and defined by the Intensive Care Society, and kind of determines what kind of support you can have on each level, if you like, and kind of the appropriate staffing and skill mix that goes with it. So we all know what a ward is. A ward is just, a ward is a ward. It has normal levels of nursing care. It doesn't do anything above and beyond normal levels of nursing care or midwifery care, I suppose, in obstetrics. Level 1 is what we would call enhanced care. So in this area, you can do some invasive monitoring and you can offer some single organ support. So that would be something like an arterial line, a bit of vasopressor, or some non-invasive ventilation, but only one of those things. And that's, for example, what we offer in Leicester Royal in the enhanced care unit on maternity. Level 2 care is level 1, but you can have 2 things that need support. So, for example, you could have a vasopressor and some non-invasive respiratory support. And coming with level 2 requires the staff to have more kind of competencies. And then level 3 care is what I'm going to call proper intensive care. So that is where we can offer things like invasive ventilation, multi-organ support, more advanced blood pressure and inotropic support, renal replacement therapy, and then, as Kaz is going to talk to you about later, things like ECMO. And then in certain circumstances, there are other intensive cares that can offer bridge therapies to definitive management. So, for example, something like a left ventricular assist device to, perhaps go on towards cardiac surgery or something like that. Now, how do we supply these different levels of care? So, how do we supply these different levels of care? Well, it's about the competencies of the people who work there. And there are different models of different ways of doing this. So there are some guidelines set out. So there's the care of the critically ill woman in childbirth, which was a document from the RCOG and the Intensive Care Society in August 2018. And that talk sets out some kind of standards around just critical care generally and what should be available to these women. And then in terms of skill set, there are different ways of kind of achieving your enhanced care, or in some places you can offer level 2 care. And what you can do is you can either, there are competencies basically laid out, and the two ways of doing it, you can either have midwives who train with critical care competencies, so for example, how to look after arterial lines and such like, or you can do it the other way around, and this is the way Nottingham do it, where you have intensive care nurses with kind of maternal specialist competencies, and what they do is rather than admit level 2 patients to intensive care, they lend out intensive care nurses to support the maternity unit, and there are different ways of doing that. But at the moment, and if I'm completely honest, I'm not entirely sure how it works in Leicester Royal, which we can talk about at the end. And the fact that I don't know how it works is probably not a fantastic sign. So the particular challenges to intensive care for maternity patients, you know, they're nothing particularly unexpected, really. So the maternity patients are unusual patients for intensive care. Hopefully somewhere in and about this there's a baby, and that baby is either still inside the mother, or it is probably on, well, often on neonates, or it's being looked after by somebody else. And there is often, you know, there's a big drive around reuniting those people. There'll be lots of complicated decisions about delivery, and we've had a lot of discussions about this, particularly with COVID. The family dynamics can be even more complicated around maternity patients than everybody else, partly because everybody desperately wants the mother and the baby to be back together again, which of course is perfectly reasonable. I've called this next one patient capacity. So we've had a number of patients who, particularly around COVID, have had difficulties in appreciating what is actually happening to them. And I think there's been lots of misinformation, particularly with COVID and vaccinations and how sick people are and what kind of care they need. And this can be a real challenge to us, trying to work out whether they have capacity or whether they're just making what you might conceive to be irrational decisions. The physiology, obviously, of maternal pregnant women is different, and we're going to talk a little bit about that in a moment. The treatment options, particularly as they evolved over the last 2 years for COVID, presented a number of challenges in that initially I think there were a lot of questions about, should we be doing this to pregnant women, should we not doing this to pregnant women? But again, I'm going to talk a little bit about that further on. And another challenge would be what the situation the patient actually turns up in on ITU. So for example, somebody who's had a big massive hemorrhage and a lot of blood given to them might then go on to develop transfusion-related acute lung injury or fluid overload. And there's sometimes differences of opinion about how to manage the patients once they've come to intensive care. So for example, somebody's had a massive hemorrhage and then preeclampsia. You know, anecdotally, I know that intensive care always ends up giving more fluid than perhaps the obstetricians and the obstetric anaesthetists would like. And that is something to work on moving forwards. So some of the challenges, I'm going to very briefly talk about maternal physiology. So I'm sure most people know this stuff, but it's the stuff that comes up in exams for anaesthetics and intensive care quite routinely. So I'm not going to go through it because there's a lot of words on this slide, but essentially obstetric patients do not behave the same way that normal, that's not the right word. Obstetric patients don't present, pregnant patients don't have the same physiology as non-pregnant women, if that makes sense. So things like you can have an increased plasma volume, which will lead to a dilutional anemia. It will lead to kind of your creatinine looks lower than it would normally. You can have issues around decreased systemic vascular resistance. You end up, from a respiratory point of view, you have essentially a lower lung capacity, but you increase your respiratory rate to compensate, which can make the blood gases look a bit abnormal. But then you are more difficult to ventilate because you have something reducing your lung compliance, essentially. And then other just purely practical point of view from kind of managing patients, you know, they can be sometimes a little bit fluid overloaded. They are more difficult to intubate. they're more likely to have reflux, and then they are more difficult to position. For example, if you have to turn somebody prone, it's more difficult because there's a big bump in the way, all those kind of things. So all of those things present as challenges that we're not used to dealing with. And what we need to make sure is that we don't miss things or get things wrong because we misinterpret some of the physiology. Which leads me on to the recognition of unwell maternity patients. So these are a few slides, again, I've stolen from a different talk at the ICS, but is deterioration really an issue? Well, Embrace, the Healthcare Safety Investigation Branch, Each Baby Counts, and the Ockenden report all suggest that it is an issue. But why is it an issue? And I think it's because these patients have different physiology and it's difficult to identify when they are abnormal. And then if you do identify that something's abnormal, what do you do to then go on to appropriately escalate it and come up with a management plan? So this is something that you may have seen. It's something that I've started to see more often. This just is an approach to deterioration, or the anticipated management of deterioration, which is the PEER strategy, which is, so P is plan, prepare and prevent, which we're going to talk about, and I, identify, and then you need an appropriate escalation and an appropriate response in a kind of stratified and protocolized way almost. So in Leicester, we use, so normal patients who are not anything to do with maternity go onto the National Early Warning Score. And outside of maternity, the way that Nerve Centre works in Leicester is that patients go onto the National Early Warning Score. Now, maternity patients in Leicester go onto the MEOWS score, which is the Modified Early Obstetric Warning Score. And this slide here shows the variation in maternal early warning scores around the country. So there are lots and lots of different scoring systems. There are lots and lots of different ways to interpret them. So some places have a total score, Some places have a system where, for example, if you score a certain number in one colour or a red or whatever, then you escalate the care. You kind of escalate up the pathway according to that. But as you can see, there's lots of different variation and it's not consistent at all. So this is what we have in Leicester. This is the MEOWS score. It's a total score-based system, divided up just similar to the National Early Warning Score based on certain physiological parameters. And then there is an escalation pathway which determines the score. It is quite complicated. I mean, it's not complicated, but there's a lot of words on it. There's a lot of things to read. There is obviously if you score 1 red, then you automatically get escalated, or if you score 6, then that's the big red box where you're supposed to be reviewed by consultant obstetricians and anaesthetists and DART and intensive care and things like that. Interestingly, the bottom says a score of more than 4 of women admitted outside maternity. So this is something I only discovered this week, that from talking to the DART nurses, that the pregnant women in Leicester at the moment, because of the way Nerve Centre works, are being managed on the National Early Warning Score rather than the modified maternity score. So that's something that we need to have a look at, I think, moving forwards. But what there is a drive to have a national scoring system for maternity. So I'm just going to briefly show you this. I think the plan is that this is supposed to be rolled out at some point in next year, 2023, I think. There's been a big project, which I've had nothing to do with, but a big project to kind of standardise maternal early warning scores so that everywhere you go, the same parameters apply to the same patients from conception to, I think it's 42 days postpartum. And the differences are that there's now a diastolic blood pressure in there, the heart rate and respiratory parameters have quite a wide variation, and there's no, if you're unconscious, for example, or you've got a decreased level of consciousness, that no longer contributes to a score. But what they have added into this, we'll come on to that in a minute. So they've added some other stuff into this, which we'll just talk about in a second. But essentially, this is another total score-based system, but it only goes from, I think it goes from 0 to 12. And it's much more straightforward to interpret. And I think the plan is that this is going to be rolled out in the next year or so, or something like that. But because they've taken out certain things like "Are you unconscious?", they've added in "What are additional concerns?", and these are all things that can basically circumvent the scoring system. And actually, it's quite straightforward. You know, are you concerned? Are the woman and family concerned? Things like increased pain or significant bleeding, and then of course decreased consciousness. It's a kind of guideline to how you increase what you're doing or how you respond to it, without necessarily having to score in the boxes. Okay, so we've talked a little bit about escalation. So we're going to talk a little bit about maternal sepsis. Again, this is probably targeted more towards the intensive care trainees, but maternal sepsis isn't anything that is particularly unusual. Again, most of this is just common sense. So the risk factors for maternal sepsis are, as on the screen, they're the usual things like, if you're obese, if you're diabetic or immunocompromised, you are, or you've had an operation or trauma, you're at risk of sepsis. But then there's the kind of obstetric specific things. So if you've got significant discharge, pelvic infections, you've had cerclage, you've got prolonged rupture of membranes, or perfectly reasonably might think would put you at a high risk of sepsis. Group A strep is on the list, but I think anybody who's got group A strep is at risk of sepsis. I think probably the most worrying thing on this list, and the thing that has come to light repeatedly, and we'll talk about again when we talk about COVID, is that if you are from a Black or ethnic minority group, you are more at risk of sepsis. And whether or not that is down to kind of access to healthcare or the way you are treated when you arrive in healthcare, I don't have the answer to that. Common microbiology involved. Now, this is something they like to ask in intensive care exams. Please, obstetricians, if you have a more comprehensive list or you want to completely change this list, just feel free to correct me at the end. But it's the usual kind of culprits: E. coli, Staph aureus, streptococci, Clostridium, chlamydia, and Neisseria. There's nothing unusual in that list. And of course, don't forget that just because you're pregnant or recently pregnant doesn't mean that you can't have all the same microbiology infections that everybody else gets as well, of course, for whatever cause. Just one slide on maternal pyrexia. I'm not going to talk about maternal pyrexia because this is not something that we really deal with on intensive care, but there are pretty clear guidelines, and they're very straightforward, that if you have a pyrexia and you're pregnant or you're in labour, there's some very clear guidelines to follow, which is basically common sense. Most of them involve having blood cultures and having some antibiotics. There's nothing else to it. There's a flow chart on the inside. Of course, you can't have a talk about sepsis without showing the sepsis 6. So there is a different one for being pregnant or up to 6 weeks postpartum, but it works exactly the same as all the other sepsis 6. This is the UK Sepsis Trust one. I think Leicester has a slightly different one. But essentially, you ask the question: do you think this person is unwell? Do you think it could be an infection? And if there's a red flag, which is just a tick box, then you get a sepsis 6. And if there's not, then you go down a slightly different pathway. But either way, it still involves kind of senior clinical reviews. For people who aren't as up to date as they might be, the sepsis 6 has subtly changed in the last year or so. The principle is exactly the same. It's still give oxygen, give fluid, give antibiotics, and then we monitor things like lactate and urine output. But the difference is that now there is the expectation that a senior clinician is involved if you are scoring a red flag sepsis. When I was digging around looking at these, I thought what was quite interesting was, and I don't know if anybody uses this in obstetrics locally, but there's a telephone triage sepsis screening tool, which is basically, because a lot of the conversations I imagine you have with recently pregnant women are over the telephone, and there's a kind of tick box list to get you through to decide whether or not they need to move it, whether they need to have kind of a more formal sepsis assessment or just an assessment kind of on a less urgent basis. Just briefly to talk, well, not briefly to talk about, one of the things we do need to talk about is, moving on to the next subject, is maternal collapse. So if you collapse on an obstetric unit, then most of this stuff will be covered, I'm sure, because the people on there are used to dealing with maternal collapse. And whether or not they subsequently end up being managed, however, and coming to intensive care, this is still, you know, a useful list. But there are not an insignificant number of pregnant and recently pregnant women who come through other bits of the hospital, and it's not unrealistic to suggest that, you know, for example, at the cardiac arrest call, that as the intensive care registrar or trainee, you might meet them before an obstetrician gets anywhere near them. And it's just useful to have a kind of mnemonic for kind of working through the potential problems. And I learn everything through acronyms, which I appreciate isn't very helpful for some people. But this is something that I think it was Paul Sharp told me when I was maybe an ST3, which is ABOCHOPS, which is just an acronym to work through different problems. So we just quickly go through it. So causes of maternal collapse, anaesthetics, perfectly reasonable, high spinals, you know, intrathecal epidurals, things like that can make patients apparently collapse. Patients can bleed, B for bleeding. So I've met patients with kind of undiagnosed DIC, intracerebral hemorrhages, concealed bleeding. All of those are a possibility. I mean, also bleeding all over the floor is another possibility. E for embolism, so you know, commonly things like PEs or amniotic fluid embolisms perhaps. But then, you know, pregnant women do have strokes, they do have MIs and coronary artery occlusions. Anaphylaxis, just as much a risk of anaphylaxis as anybody else. U for uterine problems. I mean, I've written uterine atony on this, but not so much for an intensive care, from an intensive care perspective, but you know, there are various things that can happen to uteruses during surgery or delivery that can cause kind of cardiovascular collapse and things. C for cardiac disease. I mean, maternity patients can have myocardial infarctions. I've met patients who've had peripartum cardiomyopathy. I know of patients who've dissected their aortas during pregnancy. All of those things are a possibility. H for hypertension. So, you know, eclampsia or hypertensive disease. O is probably an important one because everyone gets very excited about the causes of collapse in specifically obstetric patients, but they can have, for example, cardiac arrest just like everyone else can. So your 4H's and your 4T's. P, placenta, you know, concealed abruption, that kind of thing, because you know you could be standing in ED resus meeting this person, you don't know. And then S for sepsis, which we've talked about. So, you know, when you approach the management of these people from an intensive care point of view, essentially manage them as you would anybody else to start with, but then you just need to go through a kind of list of potential obstetric causes for whatever's happening to them, to just rule these things out to make sure there's nothing you need to do about them. Okay, where are we up to? Oh, okay. One thing I'm going to talk about, well, I'm not really going to talk about, is perimortem C-section. And this is something I've never had to do, and I'd like to keep it that way for as long as possible. But it's something that is part of ALS. There's a couple of links at the bottom, which I haven't put up very effective links. So one of them is the EM3, is the Leicester's in-house emergency department kind of open access learning thing. And that takes you through to a few links and a bit of a guide about perimortem C-section. And the other YouTube link, I think, is the MCRIT. There's an MCRIT talk about perimortem C-sections. For any of the anaesthetic intensive care trainees who aren't familiar with perimortem C-section, essentially, when you've got a woman who's had a cardiac arrest, who's more than 24 weeks pregnant, or 20 or 24 weeks pregnant, which is having a uterus which is just above the level of the umbilicus. If she's had a confirmed cardiac arrest, then you need to aim to deliver that baby within 6 minutes in order to resuscitate that woman. And it is a fairly, well, I say it having never done it, a theoretically fairly straightforward thing to do, but it's about the decision making to do it. And really the point is that if you're in that situation, you just need to get on and do it, because you can't make things any worse. But I'm not going to talk about it more than that. What I would recommend is that you just go to those 2 links, or just put it into YouTube, and there's plenty of kind of quite good explanatory talks on how you do it. And it's something you should probably kind of mentally rehearse how to do. Okay. Moving on to the next bit, drugs, babies and breastfeeding. This is something I imagine you could talk about forever. So the first thing is, well, I put them in the wrong order, haven't I? The first thing is about the baby. On intensive care, we'd love for the babies to come and visit if they're well enough and the mothers are well enough. I don't see there's any reason not to do that. I think that would be a good thing. We would really like to be able to help support kind of breastfeeding for those mothers and babies if that's what they want to do, but it's not something we're very good at, and it's not something we do. So we need help from the breastfeeding nurses and the midwives and things for us to be able to do that. We have guidelines about kind of video calling when babies are on the neonatal unit. Again, sometimes it's something we're not great at. We'd like to try and be better at it, but again, we need a bit of help at the other end as well. Now, in terms of breastfeeding, there are a couple of websites and things where you can look up kind of different drugs and how how they interact with breastfeeding. It's an enormously long list, and the best thing I can say about this is we tend to give all sorts of different things to people, and if they want to breastfeed, and you don't have to be, you can still be intubated and sedated and things potentially, but you need to talk to us about what we're giving those people, and then we can try and work out between us what we can do about breastfeeding. But we really want to be able to help. It's just something that, again, we need assistance to do. Right, time to get to the elephant in the room. We can't have a talk on maternal critical care in 2022 without talking about COVID. Hopefully I've not said COVID too many times while we've been giving this talk. Right, so at the beginning of COVID, there were lots and lots and lots of different reviews and studies into kind of maternal deaths and baby deaths and what happens to pregnant women and things in COVID. And some of these are still ongoing. Have a little bit of look about some of the statistics. So again, there's nothing really that comes as a surprise. So this is about being admitted to hospital. If you're over 35 years old, you're more likely to be admitted if you're overweight. And worryingly, again, if you're Black or Asian, you are significantly more likely to be admitted. Well, this is essentially the same slide presented in a different way, but you can see the graphs and how far to the right those the data is skewed. So if you're Black or Asian, you are miles more likely to be admitted. What happens to pregnant women with COVID when they come to hospital? So about 43% have, this is up to July 2021, about 43% ended up having a cesarean section, about 10% ended up on intensive care, and about 0.4% died. What happens to the baby? About 21% were born prematurely, and about 1% were stillborn. Who is at greatest risk of intensive care admission? So it's exactly the same. So people who are aged over 35, people who have a high BMI, people with pre-existing medical problems, which is something we know, and then people who are non-white, significantly more likely to be admitted. And most of the patients who were admitted were in their 3rd trimester, which I suppose goes along partly with the usual intensive care admission statistics or enhanced care admission statistics of people who are kind of approaching the end of their pregnancy, the people who end up on intensive care, or sorry, enhanced care. The outcomes have slightly changed over time, and that probably reflects the fact that we've had different kinds of COVID. So we started off with the wild type, then we moved into the Alpha variant, we moved into the Delta variant. I don't think there's any data available yet for Omicron. And what you can see is that Delta appears to be worse than the others. So there's more likely to be pneumonia, they're more likely to need respiratory support, and they're more likely to end up in intensive care by quite some way. The availability of pharmacological management also changed. So by the time Alpha came along, we were starting to give people tocilizumab, and we were starting to give people steroids. And then Ronapreve is something which is something we give to people who haven't responded to vaccinations, has something which has also appeared. Something I think is really interesting from this slide is that only 28.4% of patients admitted to intensive care received steroids for a maternal indication. I think that's quite interesting, but we're going to just talk about that a little bit in a minute. So what the UCOS study commented on was that even women who are critically ill aren't being given specific treatment for COVID-19. And, and steroids were only given to about a quarter of pregnant women admitted to intensive care. And I think that's, I think that's quite frightening, actually. I'm not really sure what to do with that information based on our practice. I hope we're not like this in Leicester. I'm pretty sure we give most of our patients, well, as soon as they get to intensive care, they get steroids anyway. And there has historically been a lot of discussion about the kind of steroids they're being given on maternity. So they are being given steroids. The Embrace report picked out a couple of interesting things of a similar vein. So the first example, and this was in the second wave, this was a lady who came into hospital. She was not particularly well. She was assessed on the National Early Warning Score rather than a modified early warning score. And there were lots of examples of her not being given treatment because people were very worried about the effect it would have on her pregnancy. To the point where the people looking after her even explored the relationship between gestational diabetes and steroids and things. Ultimately, she was deemed unsuitable for ECMO and died after a few weeks on critical care. And the comment for this is that unless you can find a really good reason, we should be treating pregnant women with the same treatments, the same therapies as non-pregnant women. We've talked about the increased likelihood of you being admitted if you are Black or ethnic minority. So here's a specific example of an ethnic minority woman was high BMI, admitted with a couple of days history of shortness of breath. Again, she had a national early warning score, which was high, but she didn't have a maternal early warning score, a high respiratory rate, low oxygen saturations, diagnosed with COVID. They kind of thought about treating her, but decided she looked all right. She did not look sick, even though her national early warning score was 8. And then she deteriorated. She was admitted to a critical care unit at that point, gave her some dexamethasone, but that was kind of very late in the game. And then she subsequently went on to die. So again, the overriding statement is treat pregnant and postpartum women the same as non-pregnant women, unless there's a clear reason not to do so. Quick look at the perinatal outcomes. So pregnancy loss between the wild type and the delta, or wild type alpha delta. So it's kind of about 2.4% in the original COVID, and then it's kind of just below 2 in alpha and delta. But preterm birth, of the percentage who've given birth when this data was available, preterm births have increased between the wild type alpha and delta. So getting delta is not beneficial in any way for a pregnant woman. Now, there's also some statistics about vaccination, and what this slide shows is that vaccination is overwhelmingly the thing that keeps people out of intensive care. So in the pregnant women admitted to hospital with symptomatic COVID, 98.1% of those people were unvaccinated. And of those who went to intensive care, 98.7% were unvaccinated. And I think what this really illustrates is the importance of vaccination and promoting vaccination to pregnant women. And this kind of shows that overall in the Delta wave on its own, 85% of patients went on to be unvaccinated. 13 of those 13 patients, well, 13 women died. And it's, you know, vaccinations had a massive effect on reducing intensive care admissions and death in pregnant women. So the summary from the UCOS. So this is just the UCOS summary. I've got one more slide after this, I think. It's what we've talked about. So in terms of COVID, your ethnicity, being obese, being of an older age or having comorbidities massively increases your hospitalisation and severity risk. The changing variants have led to an increased risk of needing kind of advanced respiratory support and ending up in intensive care, an increased risk of preterm birth, and an increased risk of neonatal admission. There has been a resistance to treating pregnant women properly, and I'm just going to use the word properly using evidence-based medicine because of concerns about pregnancy, which, well, is something that we just need to think about moving forwards. And you know, again, and they've even put it in bold on this slide, vaccination is the way to protect against severe disease in real world situations. Right, last slide, the future of maternal critical care in the East Midlands, well, from the bit that I'm involved with. So EMMCC, so that's the East Midlands Maternal Critical Care Network, is something that is just in the process of being set up by, predominantly by Steve Cantelow, who's a guy in Nottingham, who's one of their intensive care consultants. And the aim of that is to kind of share information and share the way we do things and a bit of practice across the East Midlands. And if anybody wants to be involved in that, particularly from an obstetric point of view or an obstetric anaesthetic point of view, please get in contact with me, because I think that is something that we can do a lot with. And then in Leicester, there's all sorts of things going on. So we're about to, well, we're always reconfiguring, aren't we? So there is, the plan is that there is going to be a big new bespoke maternity building, which is going to provide maternity services for the whole city. Directly underneath that, there is going to be a big spanking brand new intensive care. And I think the relationship that we have with each other will probably change quite significantly, because we're going to be so close to each other, and we can look at how to provide enhanced care in kind of a number of different ways to work out what will work for us. I'm also led to believe that the regional maternal medicine kind of tertiary referral maternal medicine centre is likely to become Leicester because of the issues in Nottingham. But again, that's something for the future. And just the little things at the bottom, the little pictures at the bottom are in an effort to kind of try and protocolize our admissions to intensive care a little bit. We've come up with some little kind of laminated sheets, a bit like for the tracheostomies that you see on intensive care, with kind of instructions about what to do given different situations. So there's a load of phone numbers on one side and kind of a plan about what to do about babies if you're postnatal and what you need to do for antenatal admissions, and some checklists and things to make sure we've got the right kit and the right people involved. Okay, and that is the end of my talk. Does anybody have any questions?
There's someone with their hand up, I think, Mohammed.
I have joined this is very great talk actually to Martin, and I have joined in the middle. I'm not sure if you answered this question or not. So the question is, do we need to ask for delivery for all the pregnant ladies with COVID? Is that going to help or save the mother or not? Or it depends on the age of the baby, or we don't need, we just carry on with the treatment and keep this as a last choice if the baby is in distress or something, because it's very hard.
Well, no, you're right. It is very hard, and this is the eternal question that we've had all the way through COVID, when admitting pregnant women. So, and you know, up to a point, you've got two patients there, haven't you? You've got a pregnant woman and you've got a baby who is as yet still undelivered. So what is the best thing to do? And I think the only way to kind of sort that question out is by talking to the obstetricians and the midwives and kind of working together to come up with a plan. So there may become a situation where delivery is the best option. You know, if we can't ventilate somebody and we're struggling to ventilate somebody and their gas exchange is terrible, then at that point probably delivery is the best thing to do. But if we are kind of coping, then delivery probably isn't the best thing to do, because there's also an important distinction that there are patients who come to intensive care who just happen to have COVID, and there's patients who come to intensive care with COVID who happen to be pregnant. And depending on which way round they are, depends on predominantly what you have to do to manage them, doesn't it? I mean, feel free for any of the obstetricians who want to comment on that, but I think it just has to be joint decision making, because it's not an easy decision, and I don't have an answer.
I was just going to add, I think I'm talking next, and most of my talk is about when to deliver, so hopefully I can help with that answer.
It might be.
Good.
Dr. Yusuf has a comment as well, I think, before he has to leave.
My comment was just going to be to say exactly the same as Martin, and also as I saw Dr. Siddiqui pop up, we had an extensive conversation between multiple specialties a couple of weekends ago, and you just cannot you can't give a broad guideline for absolutely everybody. You have to sit down with everybody involved and really think about it, because you're not just dealing with one person, you're dealing with two at different gestations, and it is just worth taking the time and doing it in advance, not at the 2 seconds before you realise you need to deliver someone.
Any other questions?
I think Mohammed put his hand up again.
Sorry for multiple questions, but I want to ask, because I was in a situation which was the most stressful situation for me in the last month, while I was in need to prune a pregnant lady. If there is any tips or tricks so can anticipate any problems while pruning a pregnant lady. I was in a fear that I was scared that she may get delivered once I get her pruned. So what can we do in this situation, or what precautions that we need to take in pruning pregnant ladies?
Go on, Farah, one of us.
Do you want to listen to my talk, Mohammed? Because I've got a couple of slides on phoning in pregnancy.
Oh, sorry, but I didn't
Still
realize.
debatable, but yeah, if we could have this discussion again after my talk, it might give you the advantages and disadvantages of pruning in pregnancy.
Kaz might talk about it as well.
Yeah. Shall we move on to then you, Dr. Siddiqui? So Dr. Farah Siddiqui is one of the obstetric consultants at UHL who has extensive experience in managing patients on intensive care and on ECMO. So we're really looking forward to kind of hearing her. And she's, as she already alluded to, who's going to talk about the decisions to deliver these women as well. Thank you, Dr. Siddiqui.
So thank you. My name's Farah Siddiqui. I'm a consultant fetal maternal medicine based in Leicester, and basically I'm the obstetric lead for the patients who are pregnant who are on ECMO. So I spend many a dark hour over in Glenfield working along with Kaz and the other ECMO consultants, and I'm just going to talk about my experience of managing these women and what we've learned and what we've developed over the years. So I'm just going to start off with what is ECMO. So ECMO is quite a niche area, okay, and it's basically when we're taking blood out of the body, oxygenating it and pumping it back in. So it basically is just oxygenating, removing carbon dioxide from the blood. I'm just going to do a very simple overview because I know Kaz Sampson is going to be talking a bit more on the use and the indications of this later on in the afternoon. But essentially, it consists of a pump, a membrane oxygenator, a gas mixer, very large cannula, and mechanisms to warm the blood before they put it through. So although the machinery looks quite complicated, when you break it down, it is just an oxygenator. And there are two types of ECMO circuits that are used in adult patients. The first is the veno-arterial. So this is used to provide support for the heart and lungs, and it's used for patients with isolated cardiac failure that's not responding to other treatments. So it takes deoxygenated blood from the venous system and it returns it to the arterial system. So you can see it here coming out of the vein and then being pumped back into the aorta. The type of ECMO that we're more familiar with is the veno-venous, and this basically provides support to the lungs. So it's used in isolated respiratory failure when the cardiac function is preserved. And it takes deoxygenated blood, either from the femoral vein or the internal jugular vein, and returns oxygenated blood into the venous circulation and directly into the right atrium. So what about ECMO in pregnancy? So the fundamental principles of ECMO management in pregnant patients with severe respiratory or cardiac failure. So these are women who, without ECMO, they have used all the mechanical ventilatory options. And so if there wasn't ECMO, there wouldn't be much that we could offer these patients. So the management is very similar to a non-pregnant patient. However, with pregnancy, just as Martin alluded to, it does introduce a level of complexity as we need to consider both treatment on the patient and on the developing fetus. So in order to use ECMO, we have to really understand the physiological changes that take place in normal pregnancy and the risks and complications that may develop in pregnancy and the demands of the fetus. So the most information that we've learned about ECMO during the pregnancy has actually stemmed from the H1N1 pandemic in 2008-2009. But a lot of the data is actually limited to case studies and series reports. Okay, so I'm going to start off with a patient who was admitted to the ECMO unit back in 2009. Now, in 2009, Leicester was the only adult ECMO centre, and this was our first pregnant patient. So this may have been the first pregnant lady on ECMO. So it was a 28-year-old lady who'd had 2 previous deliveries. Now this is her chest x-ray, and you can see that her spine is curved quite significantly. Okay, so she had quite severe kyphoscoliosis. She also had asthma and a low BMI. And she booked in Leicester. So when she was 35 weeks gestation, she presented to A&E with a 5-day history of headaches, runny nose, cough, and high temperatures. And her observations at the time showed that she was significantly pyrexial and tachycardic, and she had a mildly raised respiratory rate. It was felt that she had a chest infection, so she was admitted to the medical wards and started on IV antibiotics. She was seen at 5 o'clock in a ward round by the consultant who performed a chest x-ray, or at least reviewed the chest x-ray, which showed the right medial consolidation and a raised CRP. So the impression was that this could be swine flu with or without labour pneumonia. So she was admitted for IV fluids, continuing the antibiotics, and she had the H1N1 swabs performed as well. So the next day, swine flu was confirmed, and she was commenced as per the protocol at that time on Tamiflu. She remained pyrexial and tachycardic. Her blood pressure was stable, but her respiratory rate had gone up quite significantly, and now she was significantly tachypneic. And despite this, her oxygen stats were still low. She was commenced on oxygen, and they asked the ITU consultant to review her because of worsening respiratory distress. Arterial blood gas showed significant hypoxia with a compensatory metabolic acidosis. She was starting to get more tired with her breathing, so the plan had been to transfer her to ITU anti-ventilator. And there was a MDT kind of discussion with the obstetrician at that point as to at what point would they advocate delivery. It was felt at the time that she wasn't stable enough and she may get worse after delivery. So the plan was to try her on ventilatory support, and if her oxygen saturations or her PO2 wasn't rising over 10 on 50% oxygen, that they would have to consider caesarean section. In fact, she continued to have worsening respiratory function, and despite 50% oxygen, her saturations weren't going above 89%, and her arterial blood gas showed PO2 of 9 with a significant base excess. So because she wasn't maintaining good PO2 despite oxygenation and ventilation, there was a further NDT discussion and a plan to perform a caesarean section in main theatres and transfer back to ITU afterwards. So grade 2 caesarean section was performed under general anaesthetic, and a female infant with a reasonable birth weight was delivered. The infant needed minimal resuscitation, and the blood loss in theatre was quite minimal as well. She was transferred back to ITU. Her respiratory failure was improving. Remember, this lady had quite marked kyphoscoliosis, so a uterus that was basically quite high and pinching on her chest, being empty, you would have actually expected an improvement of respiratory function, and that was certainly what they were seeing. However, what we saw with swine flu is they often have really, really thick secretions, and so she maintained a metabolic acidosis. Later on that evening, she was having persistently low blood pressures with bronchial breathing, and it was thought that she had worsening sepsis. She was commenced on noradrenaline, and the CT scan showed that she had significant ARDS, which wasn't responding to the hard ventilation settings. She had an extremely unstable evening, and despite being turned into the prone position, she was not really improving, so was referred to the ECMO unit. So she was transferred to the ECMO unit, had an uneventful transfer, was cannulated on arrival, but despite ECMO, she remained quite difficult to oxygenate, and they tried different cannula flow settings. She actually went on to develop quite a large hematoma. So because they use quite large cannula on the ECMO unit to prevent clots, then these women need to be fully anticoagulated. So this woman did have quite a difficult course with recurrent hematomas, but also quite significant bleeding from her caesarean section skull, for which she had to go back to theatre for. So a week later, she wasn't actually improving. She was cannulated again, again struggling with quite large hematomas in her neck. And the following day, her pupils were noticed to be fixed and dilated, and a CT scan showed quite a large intracerebral bleed. And so care was withdrawn. The next case is another lady who had 2 babies before. This lady was actually 25 weeks gestation and booked at Kettering. So she had been confirmed with H1N1, and on day 5 was developing quite significant hypoxia with a metabolic acidosis. Chest X-ray showed a right lower lobe consolidation, and she was on ITU and ventilated for 14 days on maximum ventilatory support and on 100% oxygen. And the team in Kettering contacted Leicester for consideration of ECMO. She had significant ARDS on chest x-ray. I haven't actually got her film there, but it was complete whiteout. But actually there was minimal splinting of her diaphragm taken on board. She's 25 weeks gestation. She was therefore transferred to Glenfield and commenced on ECMO. She was on ECMO for 10 days and then the trial off the ECMO was unsuccessful, so she was put back on. Okay, so I scanned her at this point, and there was quite significant polyhydramnios. So the amniotic fluid index was 30, and her abdomen was really quite tense. Just looking as to why there was polyhydramnios for the obstetricians amongst us, we couldn't really find a cause. But we were concerned, or I was concerned, regarding whether she would go into labour. So we gave her a course of steroids. At the time we were using betamethasone, and that was for fetal immaturity. She was starting to leak fluid. The nurse looking after her were just concerned that when they were changing her, there was fluid on her pads. But a speculum examination didn't see any lichor. She had an increase in the CRP and a white cell count. We started the usual measures that we do for prolonged or possible prolonged rupture of membrane. So erythromycin was added to the other antibiotics as well. So moving forward, she did continue to have significant polyhydramnios, and there was significant splinting of the diaphragm. Obviously, this wasn't affecting her oxygenation at all. There was this possibility of whether she had chorioamnionitis, and at this point, the lungs did seem to be recovering. So the ECMO team were wondering whether to try another trial of ECMO. But there's a significant chance that actually trying her off ECMO, we would struggle with a diaphragmatic splinting. So whether we should trial off ECMO and plan delivery. And the reasoning for doing that is actually getting off the ECMO means that she's not fully anticoagulated. And so we may not have the complications associated with delivery whilst on ECMO. So the next day, ECMO was discontinued and she had reasonably ventilator requirements. We performed an elective cesarean section. A baby boy, I should say, baby boy is born in good condition with minimal blood loss. Post-operatively, she continued to improve and she was discharged from ITU a week later. So the reason I chose these two case reports, because they showed examples of a woman who delivered and went on to ECMO, as well as the patient managed on ECMO. And as Martin was saying earlier, it does really depend on the clinical situation as to when we consider ECMO, and you have to take the whole clinical picture into consideration. So the biggest systematic review regarding postpartum patients on ECMO was this one here, which was basically case studies or case reports that were carried out between Singapore, Malaysia and the Netherlands. But it really doesn't answer the question as to whether we should deliver and then go on to ECMO, or whether continue ECMO whilst the patient is on, whilst the patient is still pregnant. They did find that ARDS is the most common reason that pregnant women need ECMO, and the highest complication on ECMO was bleeding, whether that's intracerebral or related to the cannula or delivery. But the neonatal outcome was actually quite good. So considering that these were actually really sick women, 83% of neonates survived, and 90% of the women that they reported on survived as well. So when you're thinking about delivery, I think the first thing you have to think about is the gestation. Okay, so less than 20 or at 20 weeks gestation, I don't know if you can see my arrow, the uterus is at the level of the umbilicus. So in a normal pregnancy, there isn't much in the way of diaphragmatic splinting. But when you get past 32 weeks, often there is more pressure on the diaphragm. Another consideration is the physiological changes in pregnancy. I know Martin has touched on this. Okay, so the respiratory changes during pregnancy do start from the early first trimester and become apparent by the mid-second trimester. And this causes changes in the thoracic cage resulted from both the enlarging uterus and hormonal effects that makes the ligaments more lax. The diaphragm, which is seen here, is actually displaced by up to 4 centimetres as we get to term. And the potential loss of lung capacity is partially offset by the widening of the anterior, posterior and transverse diameters and widening of the subcostal angle. And these changes actually continue 6 months from delivery. So the total lung capacity is slightly decreased due to the upward deflection of the diaphragm. There's also an increase in the tidal volume by about 30 to 50% at the expense of the functional residual capacity, with a reduction in both the expiratory reserve volume and the residual volume. So in late pregnancy, there's a reduction in the chest wall and compliance in addition to diaphragmatic elevation by about 30%. And this basically results in a reduced total respiratory system compliance. On top of that, you have to think about the hormonal effect on the baroreceptor. So progesterone actually reduces baroreceptor sensitivity to carbon dioxide, and this results in an increase in tidal volume and an increase in minute ventilation by about 50%, resulting in a respiratory alkalosis. So a pH between 7.4 and 7.47 is normal in a pregnant woman, but also the partial pressure of arterial carbon dioxide is about 30 to 32. I've only got millimetres of mercury here, but that's partially offset by metabolic acidosis due to an increase by bicarb excretion as a result of the maternal kidneys. So this reduces the buffering capacity and renders pregnant women less able to adapt to metabolic acidosis. And this is really important when we're thinking about a septic patient. In addition to that, you have to think about the oxygen consumption of the fetus, and that's increased by about 20% in late pregnancy. And this lowers the patient's oxygen reserves. So from the cardiovascular changes, this also begins in the first trimester and plateaus later in the second trimester. And Martin has already alluded to the changes that we actually see in the parameters. But in late pregnancy, the compression of the aorta and the vena cava from the enlarging uterus can decrease venous return and also cardiac output, particularly when the patient's in supine position. This resultant decrease in venous return and cardiac output may lead to a drop in blood pressure. And in that setting, the impairment in abdominal blood flow, including to the uterine vessels that can occur, which can affect the placenta and can cause fetal distress. So the physiological changes in pregnancy are really important when you're thinking about when to deliver. And they are particularly more important as you get past 32 weeks gestation because of the challenges both on the diaphragm and on the cardiovascular system. So in addition to that, you have to think about the paradox of pregnancy. So in order for the fetus to survive, it has not to be, so that the immune system of the mother should be relatively adapted, so that the fetus isn't rejected, because the fetus contains both paternal and maternal derived antibodies. So the fetal antigens actually suppress cell-mediated immunity while retaining normal humoral immunity. And the majority of these changes actually occur at the placental level, but it may also affect the systemic immune system in response to infection. So although pregnant women aren't immunosuppressed in the classic sense, the immunological changes of pregnancy may induce a state of increased susceptibility to certain intracellular pathogens, including viruses. And these adaptations may actually impair the maternal capacity to respond to infection. And certainly what we found during the swine flu pandemic is that women who were delivered, they actually took quite a hit postnatally, and their immune system made them more susceptible to other kind of infections. And the immune system and the mechanisms for sepsis is really, really complex. So this has actually been taken from the TOG article on sepsis that's recently been published. And I would encourage the obstetricians just to read it, because it's quite interesting how pregnancy and how sepsis interacts in pregnant women. So just quickly regarding ARDS, as we mentioned, this was the most common cause for women needing ECMO. And as I said earlier, there should be no differences in the management of pregnant and non-pregnant patient. The only consideration is at what point you deliver. It's important to have adequate maternal oxygenation saturation for fetal well-being. So we tend to run the oxygen sats higher and not let them fall below a certain level. Excessive alkalosis can also have an adverse effect on placental perfusions, and some studies have shown that Doppler changes occur in the fetus as a result of maternal alkalosis. But whereas maternal acidosis is actually reasonably well tolerated by the fetus. And you also have to think about fetal risk associated with any treatment that we give. So we work quite closely with the pharmacists when we're thinking about new treatments. So when do we deliver? So this is a decision-making model where it's quite important to think of these three areas when we're considering delivery. So first of all, the maternal status. So what is the indication for ECMO? How many days has she been on ITU, and how many days has she been on the ECMO circuit? Is she on vasopressors? Is there any evidence of clinical deterioration? In addition to that, you have to think of what comorbidities does the woman have? Does she have a raised BMI? In that first case, the lady had severe kyphoscoliosis. So when we were if she had been on ECMO, when we're thinking of discontinuing ECMO and having her back on mechanical ventilation, she probably wouldn't do well because of diaphragmatic splinting. But also, has she had a previous VTU? Does she have any heart disease? Then you think about any obstetric complications. So has she developed preeclampsia? What's her blood pressure? Is she more difficult to control her blood pressure? Is she more agitated? Because actually we've had a few ladies who've laboured on ECMO, and the main reason we found out that they were in labour was because they were more agitated and were needing quite a lot of sedation to control them. So a lady who is getting more agitated, it's important to do a vaginal assessment just to make sure she's not labouring. And then my last point is actually the fetus. Okay, so what gestation are we at? Is this a fetus that will survive if we were to deliver? Do we need the neonatal team present? And also, what kind of tests are we going to do to monitor the pregnancy or the fetus whilst she's in ITU? And I think at every point we have to have emergency plans. So what are we going to do if she all of a sudden delivers? In Glenfield, we used to have a children's PICU when Children's Hearts was there, but that's actually been moved across to the Royal. So there is no paediatric support over there. There is a home birthing unit, so we do have delivery equipment over there, but we don't have any caesarean section equipment, and we don't have a resuscitator. So every time we have a pregnant lady, we have to make plans to have all this equipment shipped over there. Okay, so it's just important to have clear plans for everybody involved as to what equipment we need and at what point we will think about delivering the fetus. So when we're thinking about at what point are we delivering a fetus, we have to think about neonatal survival. So the neonatologists are now attending deliveries less than 23 weeks, so at 22 weeks gestation. Now these are for healthy women who actually have had no complications, or mainly haven't had complications in pregnancy, or often have got cervical incompetence, and that's their reason for preterm labour. So actually these survival rates may not reflect those who have actually been on the neonatal unit for some time. But you can see that at 22 weeks, babies are surviving, but actually that survival may not be sustained. Okay, so most of them do die by 6 months. Whereas when you get to 25 weeks gestation, it's almost 100% survival and admission to the neonatal unit, but 80% get to 6 months of age. Okay, and this next slide is a slide that the neonates talk through with the patients, which basically looks at the outcome for babies born alive between 20 and 26 weeks gestation. So as we saw on the previous slide, only 3 out of 10 babies survive at 22 weeks. But actually, when you look at severe disability, it's only 1 in 3 babies. So if they actually survive life on the neonatal unit, only a third will have severe disability. Whereas when you look at 26 weeks gestation, most of these babies are now surviving. Okay, so 8 out of 10 babies survive, and it's a 1 in 10 risk of severe disability. Okay, so this is quite a useful slide or tool when you're actually discussing the timing of delivery. So how can you optimise antenatal management to improve neonatal outcomes? So there are four areas that we think about, and the 2 important ones for women actually on AICU are steroids and magnesium. So actually giving antenatal steroids can reduce neonatal death by 30%. It can reduce necrotising enterocolitis by 50%, and it can reduce intraventricular hemorrhages by about 45%. Magnesium sulfate is used as a neuroprotection, and it reduces cerebral palsy by 30%. So the next slide talks about how we'll give it. So the steroids is given from less than 24 weeks gestation. It often is worth a discussion with a neonatologist as to what is the value of giving steroids. On the whole, we often do give it as long as there aren't any contraindications from the maternal health point of view. And basically it's given as dexamethasone 12 milligrams IM or IV 12 hours apart, and the optimum timing is within 7 days of birth, and it's ideal to have the course completed at least 24 hours before birth. Magnesium sulfate is on the other hand given within 24 hours of birth at less than 32 weeks gestation, and as I mentioned, the reason is to reduce the risk of cerebral palsy or death. And how we give it is similar to what we use for the eclampsia guidelines. So we give them the loading dose, and at UHL we continue a maintenance dose of it. So the guideline is actually available on Insight on the UHL maternity database. And the benefit remains if it's given less than 4 hours. Now, if you give it and you haven't delivered a woman, within the next 72 hours, it probably is worth repeating a loading dose. So if you're not going to deliver, how are you going to monitor the fetus? Well, there are 4 methods that we have. The most simple method is actually listening into the fetal heartbeat. And I think this is probably the most important when they actually first attend the ECMO unit. Often they have been in significant respiratory failure, and this acidosis that they've had often leads to fetal death. So it's important to check fetal viability when they're admitted either to ITU or to the ECMO unit. And it doesn't have to be any fancy equipment, it's just a normal Doppler machine. The ultrasound scan can be used, so this is usually done by either an obstetrician or a sonographer, and it's useful to assess fetal weight. It's useful to assess fetal weight, placental location, which is particularly important in placenta previa. And it can be quite useful to assess whether there are any changes that are actually occurring. Okay, umbilical and fetal Dopplers often aren't required, but there can be an indication of chronic fetal hypoxia or acidemia. Just remember that the placenta is a continuation of the maternal circulation. So often signs of fetal distress can be a sign that the maternal condition is actually deteriorating. CTGs can be used, but do need a midwife or an obstetrician to interpret the results, and this is looking for more acute changes. So women who are in labour, we would use it for if we want to assess fetal well-being on a daily basis, then a computerised CTG can give us an indicator of the short-term variation, which can be useful. So prone positioning. So prone positioning has been used since the 1970s to treat severe hypoxemia in patients with ARDS. And the reasoning is that compared with supine positions, the line on the back, patients in prone position produce more even tidal volume by reversing the vertical pleural pressure. Okay, it also reduces the pressure exerted on the lungs due to the heart and the abdomen. And so, certainly in non-pregnant women, it has, non-pregnant patients, I should say, it has reduced mortality due to severe ARDS. But what about pregnancy? Well, it hasn't been studied. There have been case reports that have shown that, particularly in the COVID pandemic, it has been useful. There was a randomised control study that looked at proning for treating or helping the management of severe preeclampsia. But in that study, they only proned women for about half an hour in a day, and they did actually show that it reduced blood pressure. So the reason for proning is it does reduce the cavo-caval compression by the gravid uterus, and it can actually improve the PEEP. However, and it can actually reduce the diaphragmatic compression and the abdominal context, as well as the aortocaval compression from the gravid uterus if performed correctly. And certainly before 34 weeks gestation, it has been shown to be beneficial. After 34 weeks gestation, it is quite difficult to do and can actually cause more distress to the patient because it is starting to get really quite uncomfortable. So it may not be successful in all cases. It is worth trying because in some women, it does actually reduce the need for them to go on to either ventilatory support or ECMO. However, those women who aren't responding, so there are some women who desaturate quite significantly with proning. And so for them, it doesn't make sense to keep trying it. And so for them, I would say they probably won't respond to it. They may benefit from right lateral positioning or left lateral positioning, which we should be doing for all pregnant women after 24 weeks anyway. And that has been shown to be beneficial, but it may not work for all women. So what about our experience in Leicester? Okay, so this is our cases that we had during the pandemic of 2009. So we had 15 patients. Now, 3 of these women came to the ECMO unit pregnant, and they continued their pregnancy to term. Sorry, they came to the ECMO unit, had their ECMO treatment, were weaned off ECMO and actually continued their pregnancy to term. So all 3 women survived. and all 3 fetuses survived. So that is the best case scenario. So women who you can actually keep them pregnant and continue the pregnancy. So you get good outcome for mother and infant. However, there were 5 women who we had to deliver the infant whilst they were on ECMO, and this for varying reasons. Some because they weren't responding to the treatment, so mainly because we couldn't wean them off the ECMO, and there was a couple who had obstetric complications. I mentioned the lady who had polyhydramnios. There was another lady who had severe preeclampsia. So of these, 2 women died, but all the babies survived. And there were 7 women who were delivered and went on ECMO post-delivery. And of these, 3 women died, which is about 43%. So during the pandemic, of the 15 patients who needed ECMO, 5 women died. Okay, so we've also looked at the neonatal survival. So as I said, those who actually were weaned off ECMO, all those infants survived. Of the babies who were delivered on ECMO, there were 2 that were stillborn, which I haven't actually included, and then there was 1 neonatal death. And those who were delivered before starting ECMO, none of those babies died. Okay, so it just shows the importance of MDT discussions when we're thinking about delivery. So who needs to be involved? Well, of course, the ECMO team, the obstetric anaesthetist, the ITU anaesthetist, the obstetric consultant, and the neonatal consultant over 22 weeks. And then you have to have a named team who are going to be there at delivery, okay, or at least you need to have contact with for delivery. So this is the obstetrician, the midwife, the ECMO consultant, the obstetric and ITU anaesthetist, neonatal transport team and neonatal team at delivery, and named theatre coordinator. And it's always useful to have haematologists on standby as well in the event of major hemorrhage. Okay, so this is my summary of the timing of delivery. So the timing does really depend on maternal well-being. And certainly as pregnancy progresses, diaphragmatic elevation becomes more important, as does the increasing oxygen requirements of the fetus. Any decision to deliver the fetus needs to be discussed and documented clearly in a multidisciplinary team. And women who have required ECMO therapy, particularly at early gestation, so I haven't included those women who were actually less than 20 weeks gestation, and most of them, or all of them, have actually been extubated and their pregnancies continue to term with good maternal and neonatal outcome. So when you're considering the trial of ECMO, do consider how you're going to ventilate the patient afterwards and whether the lungs have recovered significantly. So finally, how are you going to deliver the infant? So there have been some case studies where women have actually delivered whilst on ECMO. So these women have actually gone into spontaneous labour, and the team have been called and actually have had good outcome. We have had a patient in Leicester who actually delivered spontaneously on ECMO with good outcome as well. We have had planned vaginal births by induction of labour, but this is more challenging. It's often when we know that it's unlikely for the fetus to survive, just because our maternity unit is distant from the ECMO unit, and it's quite difficult to do CTGs and monitor the fetus sufficiently. But I think what is important is to have provisions for operative delivery. So most units would actually consider an elective caesarean section. As I've discussed before, we do have to think about the risk of PPH and make sure that we're planning for significant postpartum hemorrhage, including the risk of hysterectomy, when we're taking these ladies to theatre. And when you're doing a caesarean section, it's really important to close all the layers, including the peritoneum, just because of the risk of bleeding. Usually the ECMO team will actually run an unheparinized circuit, which can be run for 6 hours when we're planning a delivery. And this is a list of the equipment that we've made. So obstetric equipment, so delivery packs, advanced forceps if you're thinking you might need to do an instrumental delivery, and suturing equipment, the obstetric drugs, cesarean section packs, and the neonatal equipment as well. Now, on the whole, from the neonatal perspective, they actually just need a flat surface and an area just to keep the baby warm, and a team who can actually just keep the airway open and the baby oxygenated until they arrive. Okay, and they often just bring their equipment with them. I think that's all I've got to say.
Thank you very much. Really useful. I had a quick question actually about steroids, but I don't know if Kaz is going to talk about steroids in pregnancy or not. For COVID, no. I just wondered, you know, obviously we give kind of steroids for fetal lung maturity, the 12 milligrams twice. And if somebody is having steroids for COVID treatment as well, do you then still give the steroids for fetal lung maturity, or is the steroid cover that we give for the COVID sufficient to cover as well?
So prednisolone doesn't actually cross the placenta to a significant event, so that's why we use it in pregnancy, whereas betamethasone and dexamethasone do cross the placenta quite freely. So the RCOG have got a guideline on COVID in pregnancy, and they do say that you discontinue the prednisolone, give the IM or IV steroids, antenatal steroids, and then you continue the oral steroids after, I think it is 24 hours, but it is quite clearly in the RCOG guideline.
Thanks.
Yeah, sorry, my phone froze just as I wanted to ask a question. Basically, my question is, and I get that there's no sort of one size fits all answer for when to deliver for these ladies, but am I right in sort of understanding from Dr. Siddiqui's talk that really before the later gestation, so before 30 to 32 weeks, the benefit in terms of reduction in the diaphragmatic elevation and the reduction in oxygen consumption from the baby, and then the potential adverse effect of the inflammatory reaction to delivery and the immunological reaction to delivery, actually on balance, it's before sort of 30 to 32 weeks, it's unlikely to be beneficial from a respiratory point of view. That's kind of what I've understood from that, so I just wanted to check that that was a correct understanding.
Yeah, I think that's what I would. I think the take-home message I've got from looking after the ECMO patients, I think it's quite useful to work with, to have that kind of discussion with the ITU consultant beforehand. At what point would you deliver? I think certainly after 34 weeks gestation, it may be more difficult to ventilate a patient, but if you're considering ECMO treatment, I would say it probably is better not to deliver and start them on ECMO, just because they do worse. Okay, so it does depend on how sick the lady is, whether you think you're going to support she's needing, and whether you think that actually by delivering her, you're going to get away without needing ECMO or needing further support. Okay, so some women, or the majority of women, do quite well after delivery. Okay, but there's a small cohort who kind of don't do well, so they've got the severe illness, and it's often when they have got comorbidities as well. I'm sure Kaz is going to talk about it and talk about our experience during the COVID pandemic, and it will become clearer. But certainly less than 32 weeks gestation, I would probably say don't deliver unless mum's deteriorating quite dramatically and you have got the time to deliver. Does that make sense? But it's not an easy answer. I have people, because I've written a chapter in an ECMO book, I have consultants from Singapore and from Australia calling me, asking me should they deliver their patient before they start ECMO or not. So it is really challenging. But I would say call a friend, get as much consensus as to what the best call is, make sure you document it really quite carefully and speak quite closely with the ECMO team and the ITU team just to find out what is the best thing to do for that patient.
All I would say is that it doesn't
Thank
actually
you.
matter whether they've got a whether they're on ITU or on ECMO. The principles are the same. Just talk to everybody. The advantage of them being on ECMO is the ventilation doesn't actually matter anymore. So you're going to say something, Martin?
Well, no, it's just a quick comment. I was going to wait till after Kaz to bring this up, really, but because of the way the management of COVID has changed over the last 2 years, there's lots of patients who go on to non-invasive ventilation and stay there to the point where they're then declined for ECMO for perfectly understandable reasons. But I mean, I think we've only had 1 or 2 of these people, but then they end up in a situation where there's almost a window of opportunity before they fall into a total heap. And again, there's not an obvious answer to this question. It's about kind of managing risk with the combination of obstetricians and intensive care people. There's no right answer, but there are people who never get to ECMO, which is, a bit frustrating, but I understand why it happens.
I think I'll hand over to Dr. Sampson.
Thank you.
Dr. Sampson's one of the ECMO consultants at Glenfield, so I'm going to talk a bit about that for those of you that don't know her.
So this should take about 20-25 minutes, and I thought what might be helpful for both the obs and gynae trainees and the more junior ICU trainees who haven't been to Glenfield, haven't sort of seen what we do with ECMO, just to really briefly kind of expand on what Farah's already said about what ECMO is, and then I'm going to talk about our experience in COVID. Please, when it comes to, I've got one slide at the end when I'm going to talk about what we saw with pregnancy and postpartum women with COVID. Please don't put that on social media. Please don't tweet that, because it is pretty niche and it would be potentially identifiable by the relatives of people, who we've looked after. So please, definitely, when it comes to that slide, don't share that on social media. So, and just if anyone's not seen ECMO, that is our membrane lung. So that is a picture, a slightly blurry up close picture of what we use to oxygenate people. So very briefly, what is ECMO? We like an acronym that rolls off the tongue, and ECMO does quite nicely. Extracorporeal membrane oxygenation. It literally means putting in oxygen outside the body using a membrane. But it's probably a bit of a misnomer because it doesn't quite cover all the things that ECMO does. So extracorporeal life support would be a better term, but obviously the acronym doesn't roll off the tongue quite so well. This is kind of a good definition. So it's a temporary thing. It's used to temporarily support either just lungs, so gas exchange, or lungs and heart, so gas exchange and perfusion, in patients with quote unquote reversible respiratory and or cardiac failure that is refractory to maximal conventional ICU management, in patients who are really considered quite likely to die without it. It essentially works very similar to a cardiopulmonary bypass circuit that people will be on for their heart surgery. And we can either support just lungs by taking deoxygenated blood out of a major vein and returning oxygenated blood as close to the right atrium as we can, or we can return that oxygenated blood to an artery, generally via the femoral artery, and that will provide support for both your heart and your lungs. And I think this is really important. So ECMO does not in any way treat the lungs or the lungs and the heart. All it does is it buys time, and it hopefully allows time for the underlying disease to either heal, and it prevents any further damage that we could sort of cause by our machines, particularly by our ventilators, onto sort of people's lungs. And this is really important. It is a last-ditch attempt to save life when we've exhausted everything else. So you kind of need to know that full conventional treatment has been exhausted before you resort to ECMO, because it does have complications, it is invasive, so it is really a last-ditch attempt to save life. This is how it's organised. So in the UK, we have the SARF, which is another acronym, severe acute respiratory failure. And actually it's only respiratory ECMO, so it's only ECMO supporting the lungs that is specially commissioned by NHS England. At the moment, cardiac ECMO isn't commissioned by NHS England. There are a number of cardiac transplant centres in the UK who all do some cardiac ECMO, but it's arranged in a slightly different way. So what we're going to talk about today is respiratory ECMO, and obviously when we get to COVID-19, that's mainly all respiratory. So this is what we have. So there are 5 centres in England, and then there's our colleagues up in Scotland, in Aberdeen. The astute around you will realise that that is just England, and there's a gap where Wales, Scotland and Northern Ireland should be, but essentially there's the 5 centres and we all divide up the whole of the country between us. So we are that light blue patch, then we've got colleagues up in Manchester who are the dark blue patch, we've got colleagues in Cambridge at Patworth who look after the purple bit, and then 2 centres down in London, so you've got Guys and Tommies who basically look after the kind of orangey red bit, and then the Brompton who looks after all the way down to the southwest. And then with Wales, we essentially look after North Wales, and Guys and Tommies look after South Wales. We look after Northern Ireland, and then, like I say, our colleagues in Aberdeen now look after Scotland. And bless them, they used to act as our surge centre, so we would look after Scotland, and then if there were patients that we couldn't get to in time and they could get to more quickly, they would help us out with that. And then they went through all the process to be commissioned as the Scottish Centre, and they were commissioned on the 1st of April 2020, not expecting that to be right in the middle of a global pandemic that none of us were expecting, but they coped pretty admirably. Who do we look after? So essentially there's the Extracorporeal Life Support Organisation, so ELSO, are a global life support organisation, and everyone who's on ECMO around the world gets we provide information, so that's got a big registry of lots of data, and this is sort of the party line from ELSO. So when you're saying you don't start ECMO until you think someone's going to die without it, what actually are we talking about kind of numbers wise? And they say you should think about it if someone's got a 50-50 chance of dying, and you should definitely think it's indicated if they've got an 80% chance of dying. So it really is taking people who we think are going to die without it and hopefully improving their chances of survival. And we look at a few things, and for the Obs and Gynae trainees, we look at something called the PF ratio, which basically just, if you are on 30% oxygen via the ventilator and you've got a PO2 of 10, you are a lot less unwell than if you were on 100% from the ventilator, which is obviously the maximum we can give to get a PO2 of 10. So that's what the PF ratio looks like. What this essentially means is we will think about it if you need 100% from the ventilator and you are getting a PaO2 only of 10. We'll also think about it if your CO2 is very high, so they're quite acidotic. And if you're thinking about the outcomes prior to COVID, of everyone, all adults that we've put on in Glenfield for respiratory failure, we've taken what is probably about a 20% survival up to about 3/4 of them get better, so 75% get better. And that's 6 months survival. And pretty much everyone who survives to 6 months will go on to survive longer, but that's the metric that we collect. And of those, so I run our follow-up clinic and I see them all 6 months, or try to see them all at the moment virtually, after they've come off ECMO, and about 50% are back at work. So I think that for me is quite an important metric. So that's people who've been really ill. For the survivors, actually about 50% are back at work. It's not been so good, the outcomes with COVID. First wave, our survival was about 60%, and actually waves 2 and 3, it's more like 50%. So it does work, it can save people's lives in COVID, but the outcomes aren't as good as if we compare sort of all comers before that. And these are the common and the slightly less common reasons. So basically anyone who's got acute respiratory distress syndrome, any pneumonias, whether that's bacterial, viral or fungal, bad asthma, bleeding into your lungs, aspiration syndromes, or trauma, so where you've got pulmonary contusions, and then slightly less common things, severe air leak, smoke inhalation, reperfusion injury after you've treated someone for a big PE, airway obstruction, obviously there is a time critical nature of that, and it will depend where your airway obstruction happens as to whether ECMO can help you. And then we don't do lung transplants in Glenfield, but ECMO is also used for acute graft failure following lung transplantation. And as you can imagine, for the last 2 years, we've basically been looking after COVID and not a lot else. On to COVID. So we realised pretty early on that we were about to get a tsunami of referrals through to the ECMO service, and we wanted to make it that any adult in England, sorry, in the United Kingdom, had the same sort of, you know, we would treat them all the same. So actually we would agree on certain criteria that we would give ECMO for. And remember, when we very first started, actually no one knew whether people could get better who had COVID going on to ECMO. You know, all the data we had was out of China, where I think they had a 85% mortality on ECMO. And then we had a couple of case reports from Italy, two young patients who'd been put on ECMO who'd both died. So we sort of went into this thinking, gosh, is ECMO even going to, you know, confer any kind of survival advantage? And between the 6 centres, we all agreed on pretty strict inclusion and exclusion criteria. And these weren't actually that dissimilar to what we'd used beforehand. But so essentially you needed to be really sick. So you needed to have potentially reversible severe respiratory failure. So a PO2 of 6.7 kilopascals on 100% or less for more than 3 hours, or less than 10 kilopascals for more than 6 hours. So, you know, you had to show that you were really sick. The lung injury score basically just looks at a few different things. So it looks at chest x-rays, at the level of PEEP, at the level of oxygenation, and the compliance, so how stiff or stretchy someone's lungs are, and it just gives you an easier way of scoring that. If they had really high CO2 and their pH was less than 7.2, despite sort of maximal treatment within lung protective ventilatory parameters, they needed to have failed a trial in prone position. We've talked a little bit already about prone position, and obviously that is difficult in the heavily pregnant patients. But there had to be at least a go at the prone position, because actually, as we all realised, that quite a lot of these patients would get better with proning. And then failed optimal respiratory management with lung protective ventilation after discussion with a national ECMO centre. There are a few people we didn't put on, so if they were an established multi-organ failure, that wouldn't include those who just had kidney failure necessarily, if there was evidence of severe neurological injury, or if they'd actually had a prolonged arrest. And then we were using a couple of criteria, which I won't particularly go into, it's a little bit niche. That was basically anyone who'd been on a ventilator for more than 7 days, and then slightly later on, when we started using non-invasive ventilation, it was people who'd been on significant non-invasive ventilation, so sort of more than 60% for more than 12 hours in a day, or at least continuously, because we all realised that in COVID, there are some people in whom the disease process itself just gets worse. And, you know, whatever you do to them, sadly, then they're not going to survive that. And that was more just these things wouldn't be a contraindication, but at least 2 centres had to independently look at those referrals and decide that they were a candidate. And essentially, across the country, an ICU consultant or any member of the ICU team could refer a patient to us. We started using an online form, which made it a lot easier to deal with the high volume of referrals that we had. And that also made things like second and third opinions between the 6 centres much easier to manage. And we would discuss all of the borderline cases, certainly as an MDT between us and often as an MDT between several centres, to try and give people equal equity and access across the country. Farah's sort of talked about this very briefly already. Essentially what we do in ECMO is we stick some big pipes in. This is for respiratory ECMO, big pipes into veins, and we can either put 2 pipes in, or we can put a dual lumen single pipe in, and you can either drain from the IVC and return to the IVC, which is what you've got in C there. You can drain from the IVC and return to the right internal jugular vein, as close as you can to the right atrium, or you can use a dual lumen cannula. And just to give you an idea, we talked about the big pipes. We quite like using these dual lumen cannulas, and this is our normal cannulation strategy in Glenfield. We like it because it's basically one hole rather than two holes when it comes to bleeding, but they are slightly trickier to put in, and we do need to put them in theatre under fluoroscopy guidance. And essentially what you do is you put a big fat cannula that's the size of my thumb down a guide wire, and it goes through the right internal jugular, through the superior vena cava, through the right atrium, and it sits into the inferior vena cava. And I hope you can see my pointers. Essentially, we drain deoxygenated blood from the SVC and the IVC. That whizzes off round into the circuit. We put oxygen in, take carbon dioxide back out, and then this has got another lumen in it, so it's a dual lumen cannula, and it's jetted back into the right atrium. So your right heart still has to pump that blood through your lungs, but actually it's already oxygenated before it hits your lungs. So if your lungs are not working very well, then the oxygen's already in, the CO2's out. This is what they look like when they are in. And this is just to give you a bit of an idea of the size of the pipes that we're dealing with. So that's a 50p piece. The next thing down is something called a VASCATH, which is what we would use in intensive care to provide our version of dialysis, and they're quite big central lines. And then the ECMO cannula, as you can see, a lot fatter and it's a lot longer. And just to sort of compare them, and it's to do with the blood flow. So we put in the biggest cannula that we can fit to the size of the veins, and blood flow to go onto a kidney dialysis machine, or our version of that in ICU, is somewhere about 300 mils a minute, whereas for ECMO we want somewhere between 3 to 5 litres a minute. So it's bigger cannulas to get that blood flow. This is what all the equipment looks like. So if you imagine the patient is kind of sitting where my writing is over here, with the cannulas in, you drain deoxygenated or dark blood. It goes through this, which is a pump, it's a centrifugal pump. That then goes to this canister. This is the membrane lung. And once that's oxygenated, that then is pumped back to the patient. And all this kind of gubbins here is basically how quickly we tell the machine to run, which affects the flow. You've got some oxygen going in via this green tubing here, and then pumping out someone's almost entire cardiac output to a room that is room temperature would mean that they would cool down really quickly. So this is essentially a water bath. So we heat this up and we can actually control the patient's temperature really well on it. And you don't really need to know the mechanics of it, but essentially if we want more oxygen, we need to pump more blood through the machine, and we can easily vary the CO2 clearance by increasing or decreasing the oxygen flow through the machine. The bad stuff, the reason that we only resort to it as a last resort to try and save life, is because these patients need to be fully anticoagulated to prevent them clotting in the circuit. Although, as Farah was saying, for things like planned delivery, we can halt the anticoagulation, but even if you turn the heparin off, and heparin is our normal anticoagulant that we use in these patients, they're still a bit auto-anticoagulated. You know, they've still got most of their blood volume going through an extracorporeal circuit. It munches through your platelets, it turns off your von Willebrand factor. So even if you've stopped the heparin, these patients will bleed more, and that is the major risk. They bleed pretty much everywhere. Obviously, the most worrying, including that case report that Farah talked about, is into the head. And we found that the bleeding was more of an issue with COVID-19 because it does affect your coagulation as well. The risks of intracranial hemorrhage, what we quote people, are somewhere between 5 to 10%, so somewhere between 1 in 20 to 1 in 10. And in the UK, that's not always fatal. We have had various people who've bled into their heads and actually woken up either with sort of symptoms of a stroke or sometimes with none. And in fact, I'll never forget a young patient we looked after who was in his 20s with very severe asthma, who'd actually been cannulated up in Scotland in Edinburgh, and we'd gone to pick him up. We scan everyone on CT scan sort of within the first 24 hours, scanned his brain, big frontal hematoma, you know, kind of, and we were all sort of like, oh gosh, you know, this is awful. Is he ever going to wake up? His asthma actually got better quite quickly. We woke him up. He seemed to have a slightly numb left hand, and it was a big right frontal hematoma. And I remember very clearly him coming back to my 6-month follow-up. And, you know, we always talk about the sort of physical and the psychological side of being in critical care in that. And, you know, I always ask about things like personality, memory loss, things like that. And his girlfriend said to me, they had young families, they had, I think, 3 under 6s. She said to me, he's much nicer now. He's much calmer. He's much kind of more gentle with the children. And so essentially frontal lobotomy, free with his ECMO run, that actually worked quite nicely. Conversely, after bleeding, the next highest risk is clotting. And again, we saw a lot of that in COVID-19, lots of PEs, lots of clots in places we didn't expect. And then the final problem is that actually, even with the support of ECMO, there is untreatable lung disease and their lungs just don't recover, even if you've bought them the time. So Farah's talked already quite a lot about our swine flu outcomes with sort of ECMO and our pregnant and our postpartum ladies. I joined the ECMO team in Glenfield post 2009. I wasn't here during swine flu. I've been here since sort of 2014, and the women that I have looked after who've either been pregnant or postpartum have either been H1N1. We've had certainly at least one lady that I can think about who had life-threatening asthma, and then more recently, obviously, it's been COVID-19. And we've had a few other weird and wonderful things, some pulmonary hemorrhages. The majority of the women I've looked after have been postpartum, actually, usually within that first week postpartum. My experience is if they are in sort of early-ish, you know, kind of first or the very first trimester or the beginning of the second trimester, so certainly 20 weeks or less, usually they do miscarry, and I suspect that is just the body, you know, the mum's body saying, do you know what, I can, you know, I'm very poorly, I cannot deal with this pregnancy, and they will spontaneously usually abort at that miscarry at that gestation. We talked already, obviously they need to be heparinized. There is that need for systemic anticoagulation, and so really a big problem is the bleeding risk, and particularly in the postpartum ladies who've had a section. If we can manage them conservatively for at least the first kind of 24 hours, obviously, the longer you wait post your operation before you therapeutically anticoagulate somebody, the less your risk of bleeding. So we like, if we can, to wait 24 hours. Obviously, if mum's condition is sort of so bad from a respiratory point of view that they can't wait, then you'll just crack on and deal with some of the bleeding problems. But we certainly have had ladies post-section who've then had to go back to sort of have evacuations of large hematomas, sort of, you know, we're a few days down the line. Farah's already talked about the swine flu data, and it's interesting that 15 of the pregnant patients were in Glenfield. There was actually 17 in total looking at Glenfield and Patworth and Brompton and Aberdeen's data, so we probably had the biggest case series at that point. And then I'm going to talk about our COVID-19 outcomes. So is there anything in the literature about how the pregnant and the postpartum ladies do compared to other people with COVID-19? Obviously, I said our outcomes overall in adults with COVID-19 were not as good as, you know, for any of the indications that we did before then. And there is some literature, obviously there's loads of stuff there's loads of papers kind of being churned out the whole time on COVID. On the left here, this was it was just wave 1 actually from a single centre in Texas, and they reported a case series of 9, mainly postpartum, sort of 7 postpartum and 2 pregnant ladies, and actually all 9 of those survived to ICU discharge. There were a couple who were still in hospital at the time of writing the paper, and 7 who'd been discharged home. And then I talked about ELSO, so the the Extracorporeal Life Support Organisation, where every patient on ECMO gets reported to them. So that's a massive database, it's a global database, and they published this paper, and this is up to, so the paper on the right, this is up to April 2021, so this would be for us wave 1 and wave 2, and they had 100 pregnant and postpartum ladies. Didn't actually in the registry, they didn't differentiate between the two, so these were either pregnant or within the first 6 weeks of postpartum. And of those 100 women, actually their outcomes were better than sort of matched non-pregnant women. I mean, that they were younger, the pregnant patients were younger than the non-pregnant women, but of those 100, and I've got the paper next to me, they actually had an 84% survival in the pregnant patients to hospital discharge, and that compared to 51% survival in the non-pregnant women who were matched. So there is actually better outcomes with the pregnant and the postpartum ladies in the literature for COVID.
Has anyone got questions for Dr. Sampson at all? No, I think that was really comprehensive. Thank you so much. That was really, really useful.
It is a very niche topic, though. I mean, we've now looked after in England, Wales and Northern Ireland, so discounting Scotland, more than 50,000 adults have come to ICU with severe COVID. In the first wave, 1 in 4 were referred for ECMO, but actually, if you look at the numbers, it's only between 2 and 3% in every wave that have been supported with ECMO. So whilst we do quite a lot of it in Glenfield, it is quite niche. So it is only a tiny percentage of those patients who actually went on to ECMO or were looked after in the ECMO centres.
You found the same thing that we did, though. Everybody gets clotty and everybody has a very much prolonged length of stay. At the Royal, our normal length of stay is about 2.5 days. And if you're on a ventilator, then maybe about a week with respiratory failure. Whereas for ECMO, it would take 2 weeks to die and 3, 4, 5 weeks to survive at least. So not any different. Anybody want to ask anything?
Could you put up the feedback slide, Zoe?
Yeah.
For the Obs and Gynae trainees, we're just using our normal feedback form, and I'll put a link in the chat as well. If we just decided if you're based in obstetrics, then you can complete that form and you'll get a certificate automatically emailed to you, but just be sure that you type the date in the correct format to make sure that the title on the certificate is correct. Just make sure you put your name and your email address in correctly. Thank you.
It's the same for the ITU guys. It's the normal form that we use for teaching. So you get your certificate sent to you, and the presenters get their feedback that you send for their appraisals. So I'm sure that will be very well received.
Brilliant. Well, if there is no other questions, then I just want to thank everyone again for doing this. I think it was really useful to hear from different perspectives. We're all obviously trying to get the same outcomes, but everyone has slightly different priorities. So it's really useful to hear from different physicians and their own experiences. Thank you very much on behalf of all of the Obs and Gynae trainees.
Yeah, thank you. Thanks for suggesting it, Anna. Much appreciated.
You're welcome. In that case, everyone, have a lovely weekend. I will see you soon.